Good morning and good afternoon, everybody, wherever you are dialing in from. We're going to give folks just another minute to join us, and then we'll be getting started. About 30 more seconds to let folks arrive, and then we'll get going. All right, I see more people continuing to join in, but we're going to go ahead and get started. Good morning, good afternoon, wherever you may be. My name is Grace Rubenstein, and I'm Editorial and Communications Director at Health Begins. I'm so pleased to welcome you here today to our webinar on calculating blended value to make better health equity investments. Quick note before we start, we do want you to know that this webinar is being recorded and that we will be sending both the recording and the slides out to everyone who registered after the webinar. So you don't have to try to jot down every single thing you see. And before we get into some more of the logistics, I do want to take a moment just to acknowledge that many of us may be arriving today with heavy hearts or with unsettled minds after the passage late last night of a House budget bill that makes historically deep cuts to Medicaid and safety net programs. It's a matter of deep concern for those of us who are committed to health equity and the well-being of our communities. So just want to acknowledge that and the state we may all be coming together in today. And we're grateful for your presence and that we are, in fact, together on this day. We can go to the next slide, please. And thank you to my colleague, Barbara Long, for helping us with the slides. So just to give you a sense of how this is going to work, all of the participant lines are on mute, but we really want this to be a conversation, a dialogue. So if you have a question for us, you can enter it at any time in the chat window. We're going to be monitoring the chat the entire time and reserving some time at the end of the hour to answer as many questions as we possibly can. And we're really hoping that that chat is going to be a channel where all of you who are with us today can also share thoughts and resources with each other. And we welcome resources there, not promotions, please, but anything that you think might be of use to our fellow travelers here. And just to get us started, we like to do a little practice round. I'm gonna lead it off. Please find your chat window and tell us who you are and where you are joining us from today. It's always wonderful to see the great array of people who come to these events. There we go, Mario, Kelly, Ryan, Elise. I see so many states and regions represented here. It's wonderful to have you here. So this will be a 1-hour presentation with time for a Q&A at the end. We ask everyone to bring respect, curiosity, and joy to the conversation. Can I have the next slide, please? This is what we are hoping everyone will take away from the conversation today. By the end of this discussion, we hope that all of you will be able to explain the core components of a blended value approach and their importance, especially in times of economic uncertainty, especially today, to describe how blended value methods and financial models can enable teams to better plan, assess, and sustain their investments in population health and health equity and social needs interventions. And finally, to identify at least one opportunity to learn how to calculate the blended value of your own health equity and social needs investments in your own settings to achieve greater impact and sustainability. Next slide. And finally, it's my honor to hand this over to our incredibly capable moderator, Glasha Marcon, Vice President of Learning and Innovation at Health Begins. Glasha.
Thank you, Grace. Good morning to those who are on the West Coast and afternoon to those who are everywhere else. I'm really excited to be with you all today and talking about blended value for health equity. First, I want to tell you a little bit about us. If you can go to the next slide. Health Begins is a national mission-driven consulting firm and field catalyst that helps Medicaid-serving organizations exceed health equity and social needs requirements, shifting the upstream conditions that heal and harm people and achieve long-term impact for communities harmed by societal practices. We've helped hundreds of courageous leaders and staff move upstream, and we're really proud to have advanced health equity in over 350 communities across the country. You can go to the next slide. So today we have a really fascinating presentation and then conversation focused on blended value. And we'll start out with a presentation from Rishi Manchanda that goes into, the basics, the foundations of blended value, and then we'll have a panel discussion with our three panelists, Len Nichols, a non-resident fellow at the Urban Institute and professor emeritus at George Mason University, Jessica Polardi, who's the Senior Manager of Medical Advocacy at Lutheran Settlement House, and Corey Smith, the Director of Health Equity Evaluation at Corewell Health. We're really looking forward to this discussion, and to start us off, I'll hand it over to Rishi to give us an overview of what blended value for health equity means. Rishi, go ahead.
Thank you, Glasha, and hi, everybody. Thank you so much for joining us today. If you can go to the next slide. So I wanted to frame, as Glasha mentioned, what does blended value mean? And before I move to the next slide, I just want to echo what Grace had mentioned at the top of the call, which is when we talk about value or blended value, underlying this, of course, is an understanding of values. And there is no doubt that the bill that passed out of the House last night really is not aligned with values of health and health equity or with the science of it, because it represents the biggest redistribution of wealth from the poorest households to the richest households. And we know from all the research and all the literature, as well as our experience, that there are many harms that this can create rather than the opportunity to really promote healing. So I want to acknowledge that blended value is only as important as our understanding of a common shared set of values, and how today is really a meaningful day because of what it means in terms of the ways in which we describe our values as well as approaches to capture full value. We're going to talk about blended value because it is an important method as one piece of an overall approach that we take at Health Begins to move upstream. We go to the next slide. I'll do some framing here to first say that there are some myths that we've been hearing and seeing and often trying to confront in our work, and I wonder if this resonates with all of you. In this era of healthcare financialization, financialization is a term that's defined at the bottom there. You're welcome to read that, but it essentially communicates what's been happening over the past 40 to 50 years in the US, in particular in the healthcare industry, where companies and organizations are really oriented towards decision-making driven by financial strategies rather than other productive activities, with the goal of accumulating capital rather than other priorities. And so in this era that we're all a part of, that's been going on for decades right now, there's a few myths. The first is that we must show financial ROI to demonstrate value. I think for anybody who's done any work in the front lines of either healthcare or social services or public health, we know that the fact is that financial ROI analyses are important, but are not well suited to capture the full scope of economic, social, or environmental value of interventions. The second myth is that everything worth investing in requires a positive and short-term financial ROI. Well, the fact is that every investment of resources, time, or capital has potential financial, potential economic, potential social, and potential environmental value. In each domain, value can either be net negative, neutral, or net positive, and can be generated over different time horizons. So it's not just about believing the myth that everything has to have a positive short-term ROI financially. The next myths, if you could click again, Bobby. The next set of myths are that financial professionals, this is a belief that I've heard a lot from public health and healthcare folks who think deeply about mission. There's this myth that financial professionals, including actuaries and financial managers and CFOs, only care about money and financial ROI. It's a deeply embedded kind of myth that is belied by the fact that many financial professionals who work in healthcare and public health and social sector organizations are deeply mission-driven and are looking for opportunities to take their expertise and skill sets to apply to the work. The other myth is that health professionals should only care about, and not financial professionals, but health professionals should only care about maximizing health and not really have any concerns for costs. Our job is to maximize health. The reality is if you're managing any kind of time, resources, or budget for yourself or for a team or an organization, you're already responsible for, and of course, interested in the most cost-effective ways to optimize health. And lastly, the myth is that it's impossible to put an economic value on health. Well, the fact is it is difficult, but economists, and frankly, all of us do this every day, but economists, especially with the science of economics, are doing this every day, and that work is vital to inform health policymaking advocacy. For example, the work of the Congressional Budget Office that scored the bill that just came out shows that the economic impact profoundly for the health policies that are being promoted by the House bill. This is vital information, and so we do need to be more sophisticated in understanding financial and economic analysis when it comes to describing the value of health. So the next slide really says, well, let's dive deeper on these myths, including the myth of the limits of conventional ROI analysis. ROI analysis has many challenges. I won't go through all of them here in the interest of time, but we've talked about this Health Begins for now almost 7 years about the importance of ROI, but the fact that it's limited when conventionally used because it lacks an equity analysis in many instances. There's an asymmetry in conversations between those who are often bringing it up as a conversation in healthcare as it applies to the social sector, whereas we don't necessarily bring up ROI in other conversations with the same threshold requirements in the walls of healthcare for other decisions. And lastly, ROI analyses often this leaves money on the table and doesn't reflect the full value and impact really of the work, whether it's population health work, health equity work, social needs investments. We need a better way to capture that value. So the next slide really gets to blended value, because to confront these limits, we need to identify that there are better ways to calculate and communicate the value of this work. If we go to the next slide, we want to talk about blended value and what it means. First, it originates from the field of impact investing in social enterprise. Over 20 years ago, actually in 2000, Jed Emerson helped define blended value as a concept that said that while all organizations attempt to create value of one kind or another, the central premise of a blended value proposition is that value itself is a combination or a blend of economic, environmental, and social factors, and that maximizing value requires taking all three elements into account. This is coming out of the field of impact investing as we're thinking about the field of social enterprises and how businesses could be part of providing not just financial returns, but social impact. The focus of the blended value approach as it started more than 20 years ago was to maximize the total value creation potential and performance of organizations. We're deeply informed by this work, and for the past several years, starting with the ROI calculator that we helped to develop with the Commonwealth Fund and that we now are the host of, and with other advances, we've now leaned in to adapt this blended value approach and through a lot of intense learning and experiences with partners and clients. If you click one more time, you'll see the way in which we've adapted this framework is to develop financial models and methods to use blended value to provide a better way to think and talk about this work, including talking about the financial, economic, and social value, to calculate the full value of interventions, especially social needs and health equity interventions, for investing organizations, in other words, those who are putting capital and resources to that work, as well as the value for communities. And lastly, that this method, this blended value approach, sheds the limitations of conventional ROI analysis to fully unlock the opportunities for collaborative financing. When we have better financial models, we can actually unlock better financial mechanisms to invest upstream. So the next slide really gives you a quick snapshot here of some of the measures of value that we then use in this blended value approach. ROI analysis, which assesses financial performance, value on investment, which quantifies intangible economic benefits that sometimes have tremendous value for an organization, but don't have a dollar figure attached to it. It turns out there's a method to be able to assign monetary value to things like patient satisfaction or decreased no-show rates or other important economic impacts, as well as finally social ROI methods, which measures the social value or impact on stakeholders outside of the investing organization. So a case study, if we go to the next slide, that I want to show is one that demonstrates that blended value methods and financial models can really help organizations assign value in a much better way and calculate financial, economic, and social benefits, not just financial only benefits, for population health investments and programs. You can see the depiction on the slide here of financial benefits, some examples of organizational benefits that have economic value, and then societal benefits for any given intervention, for any given maternal health program or doula intervention or food as medicine program or community health worker program. There are a variety of financial, economic, and social benefits that we can do a better job in capturing, communicating, and calculating. if you go to the next slide, this is a case study from work we did with our partners at Health Collab with a health system in the East Coast that used the blended value approach to be able to define a better complete picture of the benefits, financial, economic, and social, of a community health worker program. And you can see some depictions there of the financial model reports on the right-hand side, where we identified the value drivers and the different methodologies that created that. So this is a more complete picture, and I think the next slide is a preview of something that we're now doing to take the lessons we've learned over the years and now start to make these more accessible, more available to folks through a course that Glasha and others on the team have created, launching in July. You can use the QR code here to be able to scan now. Please take a beat to scan it so you can express interest if you're interested in learning more about it, as well as to sign up so that we can fill the slots that we have available before July. And these are examples of the ways in which we're trying in today's webinar and in the work we do every day with our partners, as well as in these courses like this one, to really help us adapt the blended value approach from impact investing for the needs of health and health equity. So with that, I hope that was a sufficient primer. Glass, I'll turn it back to you.
Thanks so much, Rishi. That was great. If you go to the next slide. So we now will turn it over to a few folks that we've had the pleasure of either working with or learning from who have been applying blended value in their work. These are folks who have moved beyond conventional ROI and are incorporating economic and social value into how they calculate and communicate value, to their stakeholders, and bold leaders. They're very bold leaders. So we're really excited to have them here. So to start us off, I would love if each of you could introduce yourselves and your organization. So we'll start with Len and then go to Jessica and Corey.
Hi, Glasha, and thanks for having me, Rishi. I'm Len Nichols. I'm a simple country health economist, but I'm a non-resident fellow at the Urban Institute, trying to apply some of this stuff in the real world.
Thanks, Len. Jessica.
I am Jessica Pilardi. I work as the Senior Manager of Medical Advocacy in the Bilingual Domestic Violence Program at Lutheran Settlement House in Philadelphia. And I oversee a team of advocates who are doing direct domestic violence advocacy in the healthcare system.
Thanks, Jessica and Corey.
Hi, everyone. My name is Corey Smith. I'm the director of our Health Equity Evaluation, Assessment, and Analytics team. We call it the HEAT team at Corewell Health, which is a 21-hospital health system, integrated health system in Michigan. And our team primarily supports our Office of Community Health Impact and Belonging, our community health work, and yeah.
Thanks, Corey. All right, so to get into our conversation, the first question I want to ask you all are, what challenges with conventional return on investment analysis were you experiencing? And we'll start with Len and go in the same order for this question.
So I'm glad we only have 40 minutes left to talk about the challenges, but I think the first one to think about is people's time horizon is different. And it's just unambiguously true. Some people work for organizations that require a 12-month response, and some people have longer views. And so that time horizon is a big deal. But I would also say it really comes down to how do you measure things that people know matter, but they don't yet have a way to measure. And that's why I'm so excited about the framework y'all are working on. And as you know, one we've been working on as well. Vism, if you want to put that little site in the chat, that'd be great. There are lots of ways to think about this, but all of them are improved by thinking about the way Rishi and his team have framed it. So I'm excited about the fact that we're thinking in similar ways. We got to go beyond financial ROI, period.
Thanks, Len. And Jessica, what kind of challenges were you experiencing in your organization and work?
So we partner with a few healthcare organizations in Philadelphia to provide direct on-site domestic violence advocacy. We had partnered with several of them for almost a decade, right before COVID hit. And COVID really kind of, it really threw everybody for a loop. But right before COVID, we had this really interesting meeting with one of our healthcare partners that we had been partnering with for a really long time, where they brought myself, just a supervisor for the staff, and my manager. Some of the healthcare stakeholders brought us into a room. There was a chair of OB, chair of pediatrics, a few administrators who were working on our grant. And, they shared that they were feeling really frustrated with us because they felt our referral numbers were too low to justify the funding that we were getting. And so they really wanted to emphasize that they needed us to do better in terms of just referral numbers or clients being served at least. I think we left that meeting feeling really frustrated and a little defeated because while we agreed that we wanted our referral numbers to be higher, there were several factors going into why our referral numbers were dipping at that point. We were also really frustrated that they weren't able to see a lot of the good that was coming out of, even with the lower referral numbers, these were real families who were being impacted. And they weren't kind of seeing that long-term health outcome piece that we were looking at. And so while they were just seeing numbers coming in and out and then directing that, into an ROI mindset, we were seeing real families who maybe were relocating away from a dangerous partner. We were seeing, women who were able to engage more fully in their perinatal care. We were seeing kids being able to make it to their pediatrician appointments. We were seeing folks using the emergency department a little bit less, and so we were really seeing these impacts and these outcomes that it felt like just didn't really matter as much in that room at that moment. And we were kind of told a lot during that time, I think right before COVID, maybe before the health equity conversation was really taking off. Being a nonprofit, we had a lot of these stories that, we were told healthcare doesn't really care about the cute stories. They want to just see numbers. And that just felt, really hard. And we tried to fit ourselves into that model. And it just didn't feel true to our own values as an organization. So that was a pretty significant challenge. And I think it really taught us a lot in, how we wanted to keep moving forward as an agency.
Thanks, Jessica. That's a really good example of, doing such amazing work and ROI not capturing the full picture, of the impact and value of that work. Thanks for sharing that. Corey, can you tell us a little bit about the challenges you were experiencing?
Yeah, well, I think Len and Jessica and also Rishi have done a good job of covering a lot of the limitations that I also see with conventional ROI. But my background is in evaluation, and we're talking about value, and evaluation is fundamentally about valuing. And I think that one of the limitations that I see with ROI from an evaluation standpoint is it's incredibly limited in terms of serving as a piece of evidence for deciding whether something is worthwhile or not, right? And it prioritizes, to the point, some of the details that Jessica was just sharing. It prioritizes one thing while overlooking so much more, right? And when I work with evaluation users or customers, let's say, the frustration that I think people always experience is that the design of it, that the evaluation that they've experienced in the past, they don't really feel like it fully reflects the fullness of what they're doing, right? And in some ways, I think ROI has the same limitation in that it is such a narrow way of trying to decide, make big decisions sometimes about whether something should be continued or not. And so I think that's kind of a fundamental flaw that I see in ROI. And so, yeah, I'll stop there.
Thanks, Corey. Yeah, I think many of us on the call are probably aware and have experienced these challenges. And again, we're joined by a few folks who have really gone beyond that. And so I'd love to ask each of you, tell us a little bit about the journey of going beyond ROI and 1 to 2 specific benefits that you saw from using a more sophisticated approach that incorporated not just financial, but economic and social value. I'll go in a different order this time. Let's start with Jessica.
Absolutely. I think working with this model has really, it's given us almost, it's really allowed us to buy into what we already believed for ourselves. So we saw all of these outcomes already, and we believed that they mattered. And it let us kind of go beyond this myth, right? I mean, she pointed out a lot of myths that we've been seeing. It allowed us to say, I hear you as a healthcare stakeholder that the financials and the numbers really matter, but we also know that as a movement in public health and health equity, that these other things really matter too. And so, it allowed us to think outside the box of, if we are assuming that, a person is referred for domestic violence services and they're able to leave an abusive relationship, we can assume then that maybe they will be using the emergency department less that year. We can assume that their children are going to be able to get to their healthcare appointments more often. And then it kind of keeps going from there, right? So if somebody's able to use their pediatrician office instead of urgent care or the emergency department, they're going to be able to build up a relationship with their child's pediatrician. And then maybe, especially in these times, that relationship with their pediatrician is going to be kind of the push that they need to get their kids vaccinated, which maybe they were a little bit hesitant about. And so it kind of let us build this story of, this one intervention that has to do with a very specific issue around domestic violence is going to have this really broad impact on a lot of the health outcomes that healthcare stakeholders are looking for. So it let us kind of assign these economic impacts to things that we were already seeing. And it also really allowed us to kind of dream big around, we have a lot of shared dreams together in the Philadelphia area, at least, about what we want to see as part of all these institutions where, we are helping institutions. We are founded to help people, whether that's the nonprofit sector or healthcare. That's really what we're all here for. And so we've really kind of put our heads together and thought about, what would it look like if there's less strain on pediatric behavioral health institutions, which are completely just overrun right now. And the need is so high in Philadelphia, at least for pediatric behavioral health. What impact can domestic violence agencies have on that? What impact can immigration services have on that? What impact can healthcare and pediatricians have on that? And so it really kind of just gave us the room to say, no, it actually is appropriate to dream big. I think we just get so stuck in the day to day. And it just gave us permission to do that.
Thanks so much, Jessica. Corey, can you share a bit about the benefits you saw using this approach?
Yeah. So our introduction to this, well, let me back up. The way we arrived at actually trying to implement this methodology last year was, through conversations that we were having as a team, and our VP for Health Equity Strategies, Lynn Todman, was really critical to this. But really, she was really asking this question over and over again, right? When it comes to making choices in a system where it feels like you're constantly being asked about ROI or to demonstrate the value of your work, she continuously would ask this question of, whose values are being accounted for when decisions about value are being made. And so we were really trying to look for a way to incorporate a broader set of perspectives into making choice, into defining what value would mean for particular types of investments. And so that led us to working directly with Health Begins last year, and going through a process of piloting this methodology with a nurse home visiting program that we run in some of our communities. And in doing that, we took the time and the opportunity to, I think Jessica had a nice point, sort of dream big about the consequences or the outcomes that the things that we do might impact, right? And like this work, none of this work really exist in this, in sort of a very linear state, right? There's all of these ripples that can emerge from these types of the things that we do, right? And whether it's there were some stories that emerged as we were talking with staff about patients in rural areas who had never been connected to care before, and because this nurse was willing to take the time and visit her in her home while she was pregnant, it brought her into our system, right? It brought her into becoming a patient of Corewell Health, and it got her connected to care. That's something that doesn't show up in an ROI necessarily, but ultimately can have long-term, that at scale can have implications for our organization as it builds its reputation, as it earns people's trust, and as it engages more people in some of these communities. So I think one of the big benefits was this opening up of insight about what outcomes really matter and being able to account for them in an actual methodology that then can speak to the decision makers who are often used to seeing a certain type of output, right? So the myth that finance executives don't care only about the financial ROI, I think is right. And I think being able to describe the outcomes of one's work in those terms in some way is also very useful, right? To try to get on, be able to get on a similar page, right? So I think those are some of the big benefits that we experienced from applying this.
Thanks, Corey, especially for kind of bringing in how you worked with different stakeholders to define value as a really important part of the process. And curious to hear more about kind of the reactions, from the decision makers and stakeholders. We can talk about that next. But before that, Len, can you tell us a little bit about the projects where you incorporated blended value and the benefits that you saw?
Sure. Lauren Taylor, my partner in crime, and I have applied our little model we call CAPCHI, the collaborative approach to public good investments, across 3 communities. But I want to start by making it clear, we wake up in the morning, and I think you all do too, and realize that almost every intervention upstream of the healthcare system in what we call the social determinant space, every one of those interventions generates multiple benefits for multiple beneficiaries. In economics, we call that a public good. It creates a certain sort of set of issues, but the simple way to think about it is, economists think that we invented all this stuff. In fact, of course, social workers have known this for about 100 years. So what we do is get a community set of stakeholders in a room and ask them, what do they care about? That's the simplest way to get to where you want to be. And that is, okay, what matters to you about the thing we're talking about? And in Waco, which is a concrete example I'll give you, the entire community was overwhelmed with what I will call shortage of mental health services, just in general. And in particular, we observed that the police department was just, I think the proper word is exercised over the fact that 80 to 90% of 911 was either mental health driven or substance use driven. Okay, so we listened and we said, okay, this is what you value, all right, and what can you measure? That's also important. You got to link what they can value with what they can measure. What they could measure was FTE time. The quintessential example the chief gave us was, I have a patrolman spending 15 hours handcuffed to a person in mental health extremist in an emergency room waiting for a site consult to admit the person. It's a gross waste of resources in every possible dimension. So what we did simply was, we did our little bidding and got our money, and we put a social worker in the police department, and she helped them triage the 911 calls. And we saved the police chief so much time in 2 months. He ended the experiment and hired the woman. So it cost me a publication. I could have gotten tenured at Harvard, but here I am. But I don't care. It's my greatest success story because he basically acted on what he saw. We measured what he cared about, and he saw the value in his own data system. That's the other thing. It's got to be measurable in their own system for them to really believe it. So I think that's the way to think about it. This is multiple beneficiaries, multiple goods. Ask them what they care about. Show them how they can actually measure what they care about now and how you're going to impact it. And then you kind of got them where you want them.
Thank you so much, Len. I'll start with you again, Len, this time. If you can kind of build on that and share a couple examples of, the impact that the blended value approach has had on your team or your organization's way of thinking and working. And this is kind of internally, but also with external partners and stakeholders. And I know you had a specific CHW program in Virginia that used similar methodology. So would love to hear about that.
Yeah, so I think like you said, we start with asking what do you care about and what are you worried about and what can we measure and how can we show you in your data systems what's really going on. And once you work through all the data sharing and all that stuff, what it comes down to is, can you track impact in a way that is observable? And in the case you mentioned in Virginia, there is, I don't know how many of you know Virginia, I know Steve Horan knows it very well. There's a long tradition of free clinics. Okay, and they were created for all the right reasons, and they still function because guess what? There's still uninsured people out there, and in fact, a lot of them have become what they now call hybrid. They take Medicaid, whereas they didn't take government for a long time because they didn't want the interference and the control. But now Medicaid's such a big deal, or at least it was before last night, that they're taking it. Well, this particular, and so they basically morphed into what the world would call FQ lookalikes. So this particular one was central to developing a harm reduction strategy for people who are experiencing substance use disorder. And they were applying it in a number of their sites. And so they were doing the Narcan business, but they were also using community health workers to work as peer support counselors that typically they had lived experience, that were relevant. And they would get people enrolled in and see them through treatment programs. So if you think about it from the Narcan point of view alone, you're saving lives. They documented that they had overturned over 400 overdose attempts in a year. Okay, if you just do the simple, as Rishi pointed out, the simple health economics of the value of a life saved. I won't go through it here. I'll just say it's a big friggin' number. Okay, and it's a number based upon what we as a society have said, at least until this administration, are willing to pay for people's lives. This is how we decide how much to spend on levees in New Orleans, a topic near and dear to my heart. It's how we decide how much to do with EPA and transportation, yada, yada. That value of life saved from Narcan alone, in that particular case, was over $3 billion. Okay, and then you go to the value of getting people through treatment on the other side of treatment. And there's all kind of stuff on what that's worth. And then, of course, there's needle exchange and condom distribution and all the different dimensions of harm reduction. And what we were able to show was this little set of FQHC lookalikes was generating value across various dimensions, criminal justice, employers, et cetera, healthcare, far beyond their budget. And we hope that will help them survive in this coming world. So we are.
That's fascinating. Corey, would love to hear more about the impact in your organization and working with partners and stakeholders.
Yeah. So, so I think there's two critical impacts that I'm seeing so far, and we're still relatively early in our journey with this method. But I think one of the things that we learned doing this last year was also kind of like how hard it can be to make sure that you have the data to Len's point about what you can or can't measure, right? Because as we could dream kind of big about the outcomes and impacts that this initiative might have, as we talked with the program staff and with different leaders, as we started to do the technical work of trying to access the information that we would need to measure against those outcomes, that list started to get smaller and smaller to some extent, right? And so I think one of the impacts it's really had on us as an organization is it sort of kickstarted a longer term effort to make sure we have better infrastructure for doing this kind of analysis in the future, right? So one of the big opportunities we thought was going to be available to us was being able to link some of the so this program is a nurse home visiting program that was focused on pregnant people. and had demonstrated impact in reducing the number of preterm births that people experienced. And so we figured, this would be a bit of a slam dunk in terms of being able to generate either ROI or a VOI for the organization. And we thought it would be really pretty straightforward to be able to connect those outcomes with our value-based contracts, right? But once we started to actually do the work of digging into A, the finances, and B, just what goes into our value contracts, and being able to identify which patients fall within which contracts and which patients are linked to which potential targets and benefits, it just became overwhelming. And so I think what it's really done is helped us better understand ways we can set ourselves up to more effectively measure in this way down the road, right? I think we recognize conceptually the potency of doing this kind of work and using it as a tool. And we've sort of situated it in our evaluation infrastructure as kind of a critical method, recognizing that we need to have the right infrastructure to do it. The second impact I think that this has had for us as an organization is starting to shift our thinking away from all of these initiatives that we fund, away from them as individual programs, projects, or initiatives, and into sort of a set of investments that we make, right, of time, money, and what we're really investing in is we're investing in a value proposition that we think will have some kind of long-term benefit for our patients, for our communities, or for our organization. And so it's really started to shift our thinking about the way we organize the things that we do, right, into portfolios, right, into thinking about the connectivity between initiatives and their ability to mutually support one another towards a set of broader outcomes, right? And so, it's not necessarily the direct impact of the method itself, but it's the way of thinking about the work that I think has also really been one of the things that's emerged from this experience.
Thanks so much, Corey. And Jessica, would love to hear your reflections too.
Yeah. I think thinking about blended impact blended value has had a really big impact on, we've really just given ourselves permission to be bold in how we engage with healthcare stakeholders. I think for a long time, there was such a power differential between us as a mid-sized nonprofit and these massive health systems in Philadelphia, which have just gotten bigger over time. And, before it felt like we were really in a position where we had to almost beg to convince them that we were worth their time. And this has really given us the permission to say, you have health outcomes that you need to meet, and you cannot actually do that without the community. And it's been really wonderful seeing a lot of Philadelphia healthcare systems really start to buy into that idea. And, not just with our program, but also with other Philadelphia community-based organizations. So that it puts us on just more of an even playing field, which I think is something that we had been hoping for a long time, and also didn't ever think we would get to, because, we were kind of working, it almost felt like against the people that we were trying to work with, because they had these massive budgets that we just couldn't even wrap our heads around. So, I think that it's been really great to just be able to position ourselves as a true partner at the table, instead of, just kind of this small, quiet nonprofit who was like, just give us 5 minutes of your time, and really just approach folks as, we need you and you need us. And so how can we really work together on this? And we've just, really started to think about how we can be more creative in some of the research that we're participating in some of the evaluation that we're participating in. And it's just been really good to just have a lot of creativity flowing with a lot of the folks we've been working with.
Thank you so much, Jessica. We're going to move into our Q&A portion. We have amazing questions from the group. And before we do that, Rishi is going to just summarize some of the themes that he heard from the panelists today.
Yeah, thanks, Klasha, and to Jessica, to Len, and to Corey. Just such a rich conversation. I was taking notes here about the lessons that you guys and the insights you've shared. There are three things I wanted to kind of reflect back and impart from your discussion, as well as the conversation in the chat. And I know we're going to get to the Q&As right now, but one is the reflections kind of underscore that blended value methods help us to move past a current mindset and sort of thoughts about, we can only show value based on what we can show, right? Like, here's the data that we have, here's the measures that we have, and so we can only show value based on what we currently is in front of us. So blended value methods actually help us to identify not just what we can show, but what we need to show. And then, as Corey, you were talking about, and Jessica, as you mentioned, it then helps us to close the gaps, to say, oh, well, what we need to show is here, what we can show is here. How do we develop the data and the systems and the capabilities so that we can actually get better at showing value of our work in a more complete way? So that's one thing I really resonated here. The other thing, just as a respondent here to what I'm hearing, is that blended value methods really expand the table and invite voices that are not typically heard to define value. So it's not just on the shoulders of a financial professional to calculate value, but it's really expanding the table where actuaries and advocates and financial professionals and physicians and care managers, right, and those who think about costs are all at the table. And most importantly, I think the opportunity here is to bring voices of folks from historically marginalized communities, patients, people with lived experience, community members, community partners to the table as well, as Jessica, you illustrated. So that's another thing, the expanding of the table and inviting of more people, more seats to the table in defining value. And the last but not least is that I think blended value methods, what we're seeing in experience, especially as some of you have shared today, is how this financial modeling method is not just a tool, right, for calculations. It's a process that unlocks a cascade of other possibilities in terms of system change and ecosystem change. Better internal financial management and governance mechanisms within institutions, so they can start to kind of compare notes about value in a more complete way. Better data systems, as Corey, you've been developing, and better portfolios oriented towards more prevention and upstream kind of impacts. When you can capture better value across the board of financial, economic, and social, then you can expand their portfolios to think about how to intervene. And then finally, to what Len and Lauren Taylor and others have pioneered, I think it's foundational to better collaborative financing mechanisms like CAPG and others. So those are my reflections here. The last thing I want to say is I think we have some folks on the line who are deep experts in this, including a shout out to Anthony Bug-Levine, who is the co-author of a pivotal book called Impact Investing that helped to define blended value and popularize it about 10, 12 years ago. So I just want to recognize the expertise on the line as well. Thanks.
Thanks, Rishi. So getting to our questions, I think a lot of us maybe have this question, and Ross articulated it really well, which is, with leaders wired to focus on ROI, how do you really shift their mindsets and encourage buy-in to this model? It's one thing for folks on this call to kind of feel emboldened to articulate value this way, but how do you actually get folks to, accept that definition of value and use it to make decisions?
Well, I think Rishi said it well. It's all about changing the way people think. I mean, I often feel like my job is to teach people it's okay to collaborate, even though they're Americans. And it is a step for a lot of people. And the key, I think, is what we've talked about, and that is to link what they admit they care about that they can't measure now. And let's see how we can help them measure it. And that's really what it comes down to. It turns out a lot of what they care about is being measured somewhere in that community, maybe in a health plan, maybe in a hospital, maybe in a doctor's office, maybe somewhere else. But it's being measured, law enforcement, employers, days lost from school, et cetera. It's just they don't have it at their tip. So you got to show them what they care about is measurable and either a pathway to it or a collection strategy. And then it turns out you can link what they know matters to what they're willing to put their money on. And there's an aha moment that's got to happen. And unfortunately, it happens at different speeds for different people. So this is a process that takes some time. As Rishi said, it really is a process.
If I can also add, at least from a health system standpoint, because I do think that there's been a question in my mind about just how will this land with our senior leadership team, right? In an era, in a moment where there are financial challenges that are out there in the environment, right? And I think and I will say, on the other hand, when we talk about this concept of value, or let's say even ROI, with some of our governance groups, our boards continue to push back on whether this is something we need to do for these types of investments, right? And so there's I think conflicting sort of perspective on why we do this, and should we be subjecting these types of health equity, or I'll say community benefit investments, to this type of sort of ROI oriented analysis. But I think Len said it well, that like there is an opportunity in this to be able to try to help people get to those things they know are happening, but they just haven't been able to measure in the same sort of straightforward, quantitative, especially way that they can certain financial measures, right? So finding out what people really care about, and I think this is something Rishi talked about when he came to Grand Rapids and spoke to the Corewell Health team, intentionally trying to figure out what it is that the vice president for quality is really focused on, or the vice president of population health is really focused on, or the finance leader is really focused on, trying to find out what their interests really are, and work to then align around them and find that shared opportunity is key. And when I first came to Corewell Health, which was not coming from healthcare, not being in healthcare, when I first got asked about this sort of concept of a business case for health equity, I sort of scoffed and stamped my feet. But I've come to realize that this is not just an organization filled with people who are working, who are just trying to be subversive around the goals that I have, right? It's just an organization has lots of different interests, right, across its various departments, and lots of different accountability structures. And so just trying to figure out how to sort out where the overlaps are, right? Blended value and this type of methodology is one of the ways that I think we can do that, right?
Absolutely. Jessica, I know you responded in the chat, but anything you want to add to that question?
Not much. I think, yeah, just honing in on, if it's almost like, you can really social work a lot of folks. And I think a lot of times we kind of look at like we're being social worker. If you're from a social work background, that you're working with clients, but I've also really found quietly social working stakeholders is also effective sometimes. And so, you start with where they're at, right? And so if numbers is where they're at, okay, so, here's this outcome that I think you should care about, and here's where we have numbers to reflect it. And, sometimes it's not the outcome that you really want them to care about, but you just kind of have to get the door open for them a little bit to say, I can speak your language as well. So, we looked at all of the data that we were collecting, and we thought, what story can we tell with this data that is going to grab their attention? And so, focusing on pediatrics, we said, let's collect data on how many kids our clients have. And so then we can say, not only did we get those 20 referrals a month, but we also impacted the lives of 40 of your pediatric patients by your nurses referring them to our program. So you just kind of speak their language for a bit, and I think it gives them common ground, and it they start to pay attention a little bit more. It doesn't always work, but that kind of worked for us getting our foot in the door.
Thanks for sharing that. And I will just note that this might sound kind of abstract. Part of the process is actually kind of a whole, section on narrative frames and identifying what the values of different stakeholders might be, whether they're quality and safety focused or finance focused or patient satisfaction focused. And so there's really like a step-by-step process for aligning with these different types of stakeholders and with sample messaging and ways to, find alignment. So appreciate you all sharing. Another really, important question is, how does blended value apply and or change in this moment? So, we started out this call acknowledging, the threats we're facing to Medicaid. There's also the new Medicare physician fee code rule that is one option for sustainable funding for CBOs. So curious how you all are thinking about this approach in the context of, the reality of, policy in this country.
Well, I would observe that given the cuts that are likely to emerge from the Senate version of this thing, it has never been more important to think about the multidimensional nature of value.
Thank you.
It has never been more important. And now is the time to really teach this. I mean, we don't have a lot of time, but at the same time, here's what we do have. We have a whole bunch of people around the country who, I would argue, since the Affordable Care Act, since COVID, since George Floyd, have learned, God bless them, about social determinants of health. They have learned about the connections. And a lot of these people, like Corwell and like the partners that everybody's got, they are doing it now. And it's going to go away unless they figure out how to think in this blended value way. And they know the cost of it going away. And so now is the time to absolutely be bold, Jessica. Absolutely be, hey, you need me as much as I need you, and stick together. So go forth and prosper.
Yeah, I agree. And I think I've been thinking a lot this week about, I don't know if folks are familiar with the 2 hospitals that were shut down in Delaware County, Pennsylvania. I don't know if folks have heard about that. It's created a massive healthcare desert right outside of Philadelphia. And it's near and dear to my heart because I was born at one of those hospitals. And I think that, this is really the time. I know there was also a question in the chat about some of these more for-profit entities that really don't seem to care about anything that we're talking about here. And I think, we're really in a time where a lot of people are trying to push the narrative that the things that we've been working on for the past decade or so or more don't matter. I think this is the time to bring out those stories that we've been told don't have an impact and share it not only with the stakeholders, but also with the public, because the public can relate to those stories because those are their stories, and so I think it's going to take a lot of talking, a lot of conversation, and we just really can't stop doing it. It feels sometimes very maybe optimistic, bordering on naive to say, that this is really just the time to keep our voices going. And, to a point, if there is a system, that is really just doing harm, just calling it out and emphasizing that over and over to legislators or to other groups that have more power, and maybe even forming our own collective power together as well. So I'll stop there because I'm not as much of an expert on the Medicaid piece, but stop there while we have a minute.
Thanks, Jessica. Corey, would love your
the only thing I will add is I do think, to Len's point about this shift in awareness is really something I've seen, and not only around the social determinants, but around the ways that the ways that addressing the disparities that we see in healthcare is good for business, and it's good for people, right? It's good for our communities, and the ways that people's social needs impact their health is front and center of that. And so I do think that there is a lot of opportunity, and it is going to become ever more important as people lose coverage, as people lose access to resources, to be able to try to lean into this and continue to find the connection points with other parts of, at least for me, other parts of our organization where I believe there are clear and really relevant opportunities to connect the interests that we have as a team focused on operationalizing equity and the things that they're doing, right? And it's going to just get ever more important. It's hard to even think about what these ripples are going to be from the decisions that are being made at the federal level, but I think we have to keep it rolling.
Thank you all for kind of the last bit of, or leaving us on an inspirational note. The time is now, and we really do think that with these tools, we can shift how people think about, calculate, and communicate value. So really appreciate you sharing your experiences, and I'll pass it over to Grace just to wrap us up. Thank you.
Thank you. This feels like just the beginning of a much bigger conversation and set of practices. Just to send us off into the future here, next slide, we just want to let you know that there will be a recording sent to all registrants. It's going to show up in your email, and we encourage you to watch it and share it widely. You're going to see a survey pop up on your screen as soon as the webinar closes. We would really appreciate you filling that out to help us help you even better in the future. And this is an ongoing conversation. We want to continue it on Blue Sky and on LinkedIn. We'll see you there to carry it forward. Please stay engaged. We're all moving upstream together. And thank you for being with us and sharing all your great questions and ideas today.
Thanks, everyone. Have a great day. And yes, call your senators. Take care.